Good afternoon, everyone, and welcome. Thank you for joining us for this annual Reiss-Odenheimer Lecture, which is titled "From Evidence to Impact: Leveraging Implementation Science in Behavioral Cardiology." This annual Reiss-Odenheimer Lecture was established in honor of Viola Odenheimer, whose generous donation to New York Cardiology Society actually supports the ongoing education. And on behalf of New York chapter of American College of Cardiology and the organization team, it is a pleasure to welcome you all today. And before I will introduce the speaker, I just want to go over the upcoming events. And on 29th of March at ACC 2026 in New Orleans, there will be NYACC reception, which will be from 2:30 to 4 p.m. And on 16th of April, there will be 53rd annual Arvila Berger lecture by Dr. Mobashir Sayed. He's the chief of cardiology at Albany Medical Center and expert in cardiac MRI and imaging cardiology. And on 25th of April, Brooklyn Heart to Heart community event at Brooklyn. And please try to join all these lectures and events. And now it is my pleasure to introduce our speaker, Dr. Nathalie Moise. And Dr. Moise is an associate professor of medicine and director of implementation science in IMSCI lab at Center of Behavioral Cardiovascular Health at Columbia University Medical Center. Her work focuses on developing and implementing digital health interventions for patients with both mental and physical health conditions. She earned her degree in psychology from Princeton University and completed her medical training at Mount Sinai School of Medicine and Columbia University New York Presbyterian Hospital. Dr. Moise has spent more than 15 years in health services research and leads several federally funded projects focused on improving how evidence-based behavioral interventions are introduced and sustained in real-world healthcare settings. She currently serves as MPI of both the Equip Learning Health System Center grant and Roybal Center of Fearless Behavior Change. She has published widely in the field of behavioral implementation science, patient engagement and adherence, and clinical inertia. She has also served as a faculty for implementation science training programs at UCSF, Washington University in St. Louis, and the NHLBI. In addition, she is an associate editor for implementation research and practice, a founding member of the American Heart Association's Implementation Science Committee, and the co-chair of the American Heart Association Healthcare by Food Community Engagement and Implementation Science Task Force. So please join me in welcoming Dr. Nathalie Moise, and floor is yours.
Great. Thank you so much for that introduction and for inviting me. It's really an honor to speak to all of you today. As was noted, I oversee a suite of different grants, and my job really has been really focused on developing and advancing the science of implementation and de-implementation methods. So really thinking about how do we design mechanistically driven implementation strategies and then really testing them in primary care and cardiology settings. I work both in policy spaces, in clinical spaces with funders and private sectors, really focus on a large range of implementation science projects. I do a lot of consultation work as well. So today I'm going to be really focusing, I was asked to talk a little bit about the AHA scientific statement that I chaired on leveraging implementation science to achieve cardiovascular health equity. And I'm going to highlight some recent advances since that scientific statement came out around designing strategies. Then I'm going to use a use case or a case study here for designing more precise, mechanistically driven strategies for implementing mental health treatments in cardiovascular disease patients. My hope is that you'll use these types of methods in your own work, whether it be heart failure or hypertension, and then identify some future directions for strengthening and scaling effective cardiovascular disease treatment. I'll be using a framework that goes from evidence to understanding barriers to designing strategies and then evaluating implementation work before focusing on the future directions. So a little bit of an overview. I think we all know now implementation science is everywhere these days. And so there's this gap between what we know and what we do. And the thought is that it takes 15 years, maybe even 17 years, and according to some folks, to go from the discovery to then designing our interventions, replicating those interventions, getting them into the real world, getting people to adopt these interventions. And the thought is that it takes even longer in historically marginalized populations. And so the core principles of implementation science is that there's a difference between the what, which is the intervention. It could be a heart failure intervention, goal-directed medical therapy, hypertension guidelines, depression treatment guidelines, and heart disease patients, and the stuff, the bundle that we use to get people and places to use those guidelines. And so those implementation strategies, we'll talk a little bit about those. We care about whether or not having those implementation strategies in place improve things like penetration, acceptability of the guideline, feasibility, fidelity to the guideline, and then importantly, equity and effectiveness in real world settings, right? So we care less about the kind of consented patient outcomes and more about really service outcomes and implementation outcomes. And context is key here. Like, why did this strategy work here and not there? How did this strategy work? There's also a huge interest recently in understanding how and why strategies work in certain settings or certain populations more than others. And so that's the science behind implementation science as well. And so there's these four steps that we use a lot and that we highlight in our scientific statement, from really thinking about identifying an evidence-based practice that maybe is not being used widely in a historically marginalized population, or maybe it's very known to be very effective in historically marginalized populations, but nobody's using it, right? So really spending a lot of time mining the evidence, thinking about the evidence, understanding the mechanisms. This is work that I've been doing more recently. Why did that intervention work in the first place? So what were the active ingredients of that intervention? So that when we're trying to replicate it in the real world, we're understanding why it worked, how it worked, before moving forward. And then step two really is identifying barriers and facilitators. Why is it so hard for providers, patients, healthcare systems to widely adopt this intervention, before thinking about selecting a strategy and then evaluating implementation success? And so we call in the scientific statement, and then I was also part of a Lancet Psychiatry Commission as well, of really innovating the space of drawing more from stakeholder engagement, for community participatory research for every single one of these steps, really incorporating social and structural determinants of cardiovascular health in every single one of these steps, right? And then taking a complexity science approach of maybe you can adapt the intervention a little bit more. Maybe we should be doing more interventions that emerge from the bottom up, or testing them in real world communities from the very beginning, and designing for implementation from the very beginning, so that we're not stuck with really complicated evidence-based interventions, especially in behavioral health, which are often very complex. If you think about interventions for sleep and interventions for mental health in heart disease patients, they're often multi-week. Even nutrition interventions, cardiac rehab, all of these are very long, complex interventions, and where they always design with implementation in mind and not clear. And then using some more non-experimental approaches to establish causality are some of the innovative things kind of coming out of the field. While I think more and more people are doing a great job of selecting and adapting evidence-based practices and understanding barriers and facilitators, we've seen so many of these publications recently, we sometimes get stuck at what strategy should I use in this setting? And so there have been efforts to better match strategies to barriers. You can do something called implementation mapping, where you get a sense of all the barriers. Maybe we don't have enough resources for this, or patient knowledge is a barrier, financing, and then you map them to an implementation strategy, right? So if knowledge is a barrier, then you need some educational materials. If funding is a barrier, then you need some kind of incentive. Think about ACOs and how we incentivize. These are all good behavior in clinicians. These are all implementation strategies. But what you end up with often is that because there are so many barriers, you end up with these really complex, huge implementation strategies where you're just throwing the kitchen sink at patients and at settings and providers. Another approach that's been really highlighted is letting the end users decide what implementation strategies to use. And so you can imagine I've done a lot of this, of conjoint analyses and discrete choice experiments where you're saying, okay, stakeholders, would you rather get audit and feedback in an educational presentation, or do you want some implementation team, local needs assessment? And you give them a series of questions like this, and they keep answering option A and B. And by the end, you get a sense of, hey, they always choose the option with audit and feedback, or this is the most important strategy for this particular patient. And that's great and everything, but what you end up with is something that people really like, but not necessarily what they need. Do these address all the barriers to implementation? Maybe not necessarily. It's just something that people find acceptable. And so, as you take a little bit of a historical overview of the field of implementation science, it's a relatively new field, but methodologists have really focused on building shared language, creating all of these models, frameworks, and theories, repositories of all the implementation strategies that you can use and select from. But these aren't always validated or vetted or applied well or informed by real world experience. If you think about how complex some of these frameworks are, they don't always fit the data that we have. And then on the trialist side, and I've been on both ends of these, you're usually testing a strategy at one level. Maybe it's mostly usually the organizational provider level at a time, and often one disease at a time. If you really think about it, most of our publications are, oh, let's implement this in heart failure only or hypertension only. And you often end up with these really multifaceted, really large interventions, right? We're just doing all of these different things. And there have been very few multi-level where we're focusing on the patient, provider, and healthcare system at the same time in very complex patient populations, maybe historically marginalized populations with really very limited theory-informed justification of why that strategy was chosen, right? So can we start doing things in patients with both mental health and heart disease at the same time, a little bit more complex patient populations? And so you end up with these, what we call kind of shotgun kitchen sink approaches, and they're very imprecise. It's unclear what worked, right? You see a lot of these kind of interventions where they've just thrown the huge kitchen sink at the problem. We don't know where it worked or how it worked or how, what happened here? Which of these components were absolutely necessary? And it makes it very hard to sustain. We end up with a sustainability issue, and there's really been very little focus on sustainability. In fact, only about 1.3% of public health research is focused on how do we get people to keep doing things after we get started. So my work has really focused on my first R01 on designing more precise mechanism-driven strategies for implementation and sustainability, of really thinking about, okay, these are some of the things that happen initially. Usually you're not coming in a vacuum. You're not just saying, okay, nobody has done this hypertension or heart failure guideline. It's already somewhat implemented, and it's a good time for us to understand what happened, synthesizing prior efforts, and then doing more of a mechanism, and I'll take you through this a little bit, approach where you're really targeting the reasons why your setting, your providers, your patients aren't using the intervention, and also paying attention to the reasons why the intervention works in the first place, right? So why did this guideline work? What was it about this guideline? If you're in your initial trials, there's 100% adherence, that's going to be a big problem when you try to translate that into the real world. And then really involving multiple stakeholders and users and designing strategies before mapping them back. And so really the premise is that behavior change is key. Like we can't do things without really thinking about changing people's behaviors. We can throw the kitchen sink. We've seen so many examples of this, of financing, and you could throw money at a problem, but if you can't change a person's behavior, it's still very hard to get people to exercise and eat well, right? So really understanding the behavior, designing strategies that test or that address that are seeped in behavior change theory, leveraging user engagement, user-centered design, and any of the design of the strategies that you're doing. And then the other big piece is dynamic sustainability, is that you should assume that you're going to have to adapt over time, that you're not going to be able to just turn something on and then walk away. You'll have to keep adapting an intervention, especially in behavioral health or behavioral cardiology settings, of maybe the one size fits all approach of cardiac rehab or especially like CBT for CHD patients, maybe you need to adapt that a little bit over time to better fit the context, better fit your setting, and really understand that you're not changing too much of the active ingredients, but you're changing some of the things that seemed a little bit more optional to make sure that it's a better fit within your setting. And so really I've been calling for in my work has been this more experimental medicine approach in real world settings where you're really identifying the mechanisms of why people aren't doing this and intervention, and then identifying interventions that target mechanisms, and then measuring the intervention effects so that we understand why this strategy worked or didn't work in a particular setting. So I'm going to go through a case study that kind of expands on and adds to the models that I propose in my work. And so many of you probably know this already, but depression and heart disease, they co-occur. It's very, very prevalent. About 20% of coronary heart disease patients will experience at least moderate symptoms of depression. About 50% will altogether experience either mild or moderate symptoms. There is an increased risk of all-cause mortality versus those who are non-depressed in patients with coronary heart disease. And Mendelian randomization analyses have suggested that this is not just something that kind of co-occurs. There's a very strong relationship, particularly with CAD, MI, and hypertension phenotypes when it comes to depression. And of course, racial and ethnic disparities occur in both cardiovascular disease outcomes, but also depression severity. And some of this might be because of undertreatment of both of these. There are lots of reasons for this, but there are racial and ethnic disparities for both of these chronic conditions. And so when you start looking at the mechanisms of why there's a link between these, there are lots that have come up: cardiometabolic risk factors, obesity, metabolic syndrome, diet, exercise. If you're depressed, you're less likely to have behavioral risk factor, be adherent to some of these behavioral considerations, neurohormonal activation, pro-inflammatory states, mental stress-induced ischemia, right? So lots of proposed mechanisms, especially some of the work that we've done in the past as well. And one of the key ones has been that has emerged as behavioral risk factors. So when you adjust for everything else, really those behavioral risk factors like diet, exercise, smoking are some of the key reasons that you link depression and coronary heart disease. And so some of my early work looked at timing and novel mechanisms, right? So there is a short-term relationship between depression and all-cause mortality. Even after you adjust for everything, there appears to be this relationship. And what's very interesting is that age, gender, race, ethnicity do not seem to moderate this relationship. So maybe there's worse depression severity in racial and ethnic minorities, but overall, it's more or less very similar in terms of the overall prevalence of depression and that risk. Once you have depression, regardless of your race and ethnicity, gender, or age, you have an increased risk of mortality across the board. And so my early work looked at, okay, are there other novel mechanisms? So even after you address all of these, there's still a risk. And we found that clinician inertia, so clinicians were less likely to titrate blood pressure medications in a patient who was depressed versus non-depressed, suggesting that maybe clinician factors might also be playing a role in this relationship between depression and cardiovascular disease. So when you start looking at treatment, so what works in this area, we published a JAMA review recently, and you have pretty good effect sizes overall for depression treatment, medium size effects sizes for psychotherapy, antidepressants. For combination treatment, there's an additive benefit if you combine psychotherapy and antidepressants. But when you look at this in heart disease patients, you still have medium-sized effects for mental health therapies, and CBT is more or less equal to antidepressants, and cardiac rehab may be a little bit less effective in terms of depressive symptoms. And it's pretty clear that these depression treatments improve quality of life, but there's been no impact on all-cause or cardiovascular disease mortality, except for cardiac rehab. And some have posited maybe this is because of residual effects, like maybe even after you treat these, there are still residual things like insomnia, anhedonia, fatigue that still confer that risk, or that we are not following patients long enough, right? So antidepressants, which may target more vascular and inflammatory cascades, there's more recent data that they have long-term impacts on cardiovascular disease outcomes in these patient populations. And the other piece is maybe we're not targeting the behavioral risk factors in the inertia by just doing therapy, just doing antidepressants. Maybe that's not quite enough. And so one model has emerged when you start thinking, like I said, where this is the piece where we're mining the data of trying to figure out what's the best treatment here for this patient population. Like collaborative care is a model where a care manager, often a social worker, is placed in a often primary care setting, increasingly potentially cardiology settings. They work with a primary care provider. They provide evidence-based treat to target therapy for patients. They monitor patients, and then they work with a psychiatrist. So it allows a psychiatrist to see a larger swath of patients, to review the cases. And this has been shown over and over again to improve depressive symptoms, quality of life, but also some of those other behavioral pieces that we've been talking about: access, satisfaction, depressive symptoms, perceived discrimination. So when you start thinking, is this the right intervention for me to widely implement? If it works particularly well in racial and ethnic minorities, it might be a good option. It also improves A1C and other cardiovascular disease risk factors. It reduces inertia, which I talked about, clinicians' ability to titrate medications, cardiovascular disease medications. And so this model has emerged as something that actually reduces short-term cardiac events and depressive symptoms. So making it, as I start mining the data of like, what should I widely implement in this patient population, starts becoming the ideal use case or the ideal intervention. And you might be doing this kind of work in your own spaces of what's the best intervention. We have limited resources. We can't implement everything. And so we have to start thinking and really mining the data to get a sense of what is the best intervention for us to implement in our setting. So despite all of this work, all decades of work and replicating the interventions and trying to see if they worked in cardiac patient populations, if you look at the response rates in usual care arms over the last 2 decades, I did a meta regression analysis of response rates in usual care arms, and they found that the usual care arm has basically seen no change in response rates. So this is depression treatment response rates um, over the last 2 decades. And you would expect, as we're increasingly implementing evidence-based interventions across settings, you expect some improvement in usual care arms, but we've seen nothing. And so you start looking to see, okay, there could be lots of reasons for this. Um, could it be that maybe depression treatment doesn't work as well as we thought? And you should be thinking about this in your own settings. Maybe what worked in a clinical trial may not work in real world settings. But when we look at, in community settings, first line treatment, about 42% will respond to first line treatment, and then an additional 40% will respond if you change treatment or you combine treatments or you use a second treatment. So it doesn't look like that's necessarily the only case. There's definitely a patient population that doesn't respond to the evidence-based treatments that we have available, and maybe they need newer agents and newer treatments. But more or less, if you start going into second line and combo treatments, you more or less start seeing effect. What really is going on is that 35% of patients started treatment in the first place, and then 71% of those 35 will refill their medication, and less than half will attend a second psychotherapy visit. So really just about a third are actually starting any type of treatment. And this is just the general depressed patient population. When you look at heart disease, depressed heart disease patients, even fewer. So we're talking about less than 50% are detected by their doctors, approached by their doctors, and about 4 to 10% will start therapy or medication. And there's even been few, if any, implementation efforts for collaborative care models in cardiology settings. And so when we start pulling all of this together in terms of progress on impact, it's very clear that, consented patients in a trial are not the same as patients in the real world. And impact has really been limited by lack of attention to things like adherence and patient activation and context and treatment delivery at multiple levels. And you have this perfect storm of coexisting cardiovascular disease, depression, and disparities, making implementation particularly challenging. And we're probably not paying as much attention to some of those contextual factors that really helped us understand why those interventions like collaborative care or cardiac rehab worked in the first place. And so we're seeing this kind of limited impact on cardiovascular disease going forward. So what do we do about this? And so if you start thinking again, still in our use case, I talked about designing more precise strategies for addressing these issues. And so first we did a systematic review. One of my trainees that was published in Circulation Quality and several of my other trainees that we've put together several. We've looked into this area for quite a while. Why is it so hard? What's different about cardiac patients in general, right? And so you would expect if everybody's seeing a primary care doctor, it would be more or less equal cardiac patients versus other patients. And so there's a lot on just provider staff behavior of like lack of knowledge, concerns about screening and treating heart disease patients, motivation. Is this my problem, really? Should I be the one doing this? Even primary care providers, should I be the one managing their depression? Should it be a psychiatrist, even though we don't have a lot of psychiatrists? And then on the patient side, opportunity, needing resources that meet their needs in terms of health literacy, in terms of their heart disease, making that link between heart disease and depression for them, and then motivation, this ongoing stigma, lack of ability to effectively address patient and conduct screening, lack of belief in the validity. Is this really depression or just my heart disease, right? This insight issue. And so it really sums up of like needing more personalized resources for the cardiac patients at the system level, addressing physician knowledge and motivation. And then at the patient level, really some activation and decisional conflict of reducing their conflict about treatment, giving them resources that they need, and activating patients to improve, to reduce stigma, to improve insight as well. And so we did this mechanism. I won't go through this too much, but on the left, you'll see this iterative approach. What I talked about stakeholder engagement. We had advisory boards and user tested and mixed methods and a creative team to design interventions, physicians, cardiologists over and over again, and came up with a multi-level strategy that would mechanistically address the reasons why we think that it's so hard to implement things like collaborative care and mental health treatment in cardiology and primary care settings. And so things like social support, like local technical assistance, creating a learning collaborative to make it easier at the system level, modeling change, like what works from a behavior perspective for doctors, audit and feedback works, understanding how you're doing versus others, changing the structure. So finding a way for us to bypass the doctors, the way for us to like get triage patients automatically and then have them be seen by a collaborative care program so that the doctor doesn't have to be so involved in the referral process. And then for the patients, developing educational materials that kind of personalize and activate them with some subliminal messaging. So you have all these active ingredients of like information about the consequences and salience and verbal persuasion. So we're adding really key behavioral change techniques, theory-driven behavior change techniques in every strategy that we created. And you can see that these are the barriers that each of these address. And so we created this tool, developed some problem-solving meetings with mental health providers, champions regularly at the system level, some one-time education for the providers, but the thought was that we would be able to bypass them more or less, and this kind of automated decision support for patients so that they would get a sense of what their treatment options are. Everything had some behavior change techniques in it. There was a video about male patient getting insight into his mental health condition, how it helped his kind of cardiovascular disease outcomes. And then I talked a lot about how some of the reasons why these interventions work is because they target the behavioral mechanisms, right? And so really getting a sense of how they're doing, not just with their mental health, but their behavioral risk factors like their nutrition, their smoking, the exercise, all of these other things, so that that information could also be addressed at the same time. So you're having a little bit of a multi-pronged approach. So we did something called a hybrid 2 effectiveness implementation study. We had about 16 clinics altogether, clusters of primary care and cardiology sites, both high income and low income, to get a sense of disparities in any, right? So we wanted to really make sure that this would work in a variety of settings. And then we followed patients. So a subset of patients were recruited and consented so we could look at implementation, both implementation and effectiveness outcomes in this kind of hybrid 2. And then post-implementation, we instituted our problem-solving meetings, our kind of learning collaborative meetings, our iHeart tool, and then education and summary reports to cardiologists and primary care providers within our healthcare system. And so the conceptual model is that if we can address not just, yes, on paper, it looks like we're really trying to institute things like social support for care managers across our healthcare system so they could see what other people are doing. What are you doing in your setting? Oh, that's an interesting idea. Maybe my cardiology setting can leverage the primary care collaborative care program, right? Problem-solving meetings to build capacity for mental health and cardiology settings, screening patients from the provider perspective, making things easier for them, right? So they don't have to worry about this when they have so many other things, the patient could potentially be automatically referred. And then on the patient, really improving activation, decisional conflict. We're trying to figure out which of these was a key mechanism here that we needed to kind of really address, and then look at improvements in antidepressants, exercise, cardiac rehab, and collaborative care within a collaborative care setting. So here are some of our preliminary outcomes. We had a pretty diverse patient population. About 34% spoke Spanish. Um, about 50% were Hispanic or Latino. And we had a pretty nice kind of representation, racial and ethnic minority were pretty well represented. And so we saw not a huge improvement in the BDI, which is the more stringent depression severity that you will usually see in kind of clinical trials, but we did see an improvement hot off the press from our statistician on depressive symptoms pre versus post intervention. So there were fewer depressive symptoms after the implementation of our intervention. Some of the key mechanisms that we're seeing here is probably decisional conflict, that the patients were less conflicted about which treatment to do post-implementation versus pre-implementation. And then a slight, maybe 10% improvement in self-reported treatment uptake outside of our healthcare system by patients, but not significant. We also saw a slight improvement as well in just what we call a spillover effect. So we were doing a lot of the work ourselves of trying to implement these interventions, but was there spillover across the healthcare system and all 10,000 patients or 18,000 patients across our healthcare system? And there is some evidence that yes, we did see a small improvement in depression screening rates just across the healthcare system after we implemented this. And then in terms of implementation outcomes, there was a 10% improvement, which is a lot when you think about it, for cardiologists to start referring patients for mental health treatment, talking to their patients about mental health treatment, and then almost a tripling in the number of patients. I told you initially, we see usually about, a 5 to 10% treatment rate in this patient population, a much improved treatment rate in this patient population as well. So this really suggested that targeting structural determinants like access, patient activation can improve outcomes, but it's still really hard to sustain. So once we walked away, what happens? It's very hard for us to say that this is something that might continue. And so right now we have implemented, our follow-up study is to implement now that we've seen that this could be effective, an automated way for setting all of this within Epic. So screening and everything else happens within Epic. They get the tool within Epic. And we have navigators who help those patients who are still not very Epic savvy as an additional route for doing this fully in the real world across our entire healthcare system. And we're going to see whether or not this was as effective in in this full patient population as opposed to the more consented patient population. So the last thing I'll talk a little bit about is sustainability. Like I said, once you leave, what often happens is your implementation efforts kind of go away. And so I do think it's important to do the rigorous implementation trial first, so we get a sense of what worked, how did it work, getting a sense of mechanisms that are often very, very hard to collect in EHR data, especially depression treatment data. We found that the screening accuracy was quite poor. And so it made it very hard for us to just widely implement this and get a sense of whether or not depression symptoms improved, because screening is abysmal in cardiac settings. We found about 95% of the PHQs were zeros when we just left it completely alone versus implementing really high fidelity screening, where about 30% of heart disease patients screen positive for depression in more historically marginalized populations. And so it can be very tricky when you're really thinking about the outcome that if you really want to look at, did my intervention improve depressive symptoms? You're going to have to recruit a subset, see if it worked first before widely implementing it across the healthcare system, often in this kind of multi-pronged approach. And so I talked a little bit about collaborative care and implementing it in a smaller scope. What if you wanted to do this really in a larger scope? And often implementation scientists are working at the payer level. And so we did another project where we worked with the Office of Mental Health, and they'd been implementing collaborative care in 32 sites. And they kind of threw the kitchen sink at the problem. They're like, okay, let's give them training to these clinics. technical assistance. We'll give them money to hire the care manager. We'll do some quality monitoring to make sure that they're improving outcomes like depression and other outcomes. And they expanded to more than 600 sites. And now they have multiple sites, and I'm still working with them to this day. And they expanded out to depression and anxiety. And so they said, okay, let's keep doing our technical assistance where we can coach the care managers, provide them some audit and feedback, and then fee for quality Medicaid reimbursement, right? So it was very tricky at the time to get reimbursement for this program for Medicaid participants. So they said, okay, we'll pay you more money if you can show improvement and for every patient that you enroll, we'll pay you some money as well, right? And so there's this kind of fee for quality reimbursement infrastructure. And so I was part of the evaluation of that entire process to get a sense of, okay, let's see if we widely try to implement collaborative care across the entire state instead of just our New York Presbyterian. And we found that this strategy improved uptake and impact, similar to the original trial. So that 50% of patients who see improvement in the depressive symptoms, that's what we saw in the original clinical trials. And this is also what was seen in this kind of real world setting, suggesting that, okay, this implementation strategy worked in terms of improving outcomes. They were able to reach 80% of FQHCs across the state. They also saw improvements in treatment disparities, right? So the number of racial and ethnic minorities who don't sustain depression treatment was reduced after implementing these implementation strategies, everything that you want to see. But then over time, as I continued following with them, you start seeing a reduction in effectiveness. And so this might happen if you're not looking for it. Even if you turn something on in Epic, you might start missing this a little bit over time. The effectiveness starts plummeting a little bit. Reach starts plummeting. Like, the number of patients actually reached in these settings starts coming down a little bit. So maybe your care manager was taking care of 137 patients per FTE and now 37 patients per FTE, all in the real world several years after implementation. And so I looked at some of the mechanisms. It's very clear that those early implementation strategies like training and funding and leadership support, all of those barriers were less widely cited. They're like, yeah, I know what collaborative care is now. I feel like we're okay funded. All the referrals make sense, but it's really so hard to keep the patient, providers, care managers engaged in this over time. And so engagement, so it's all behavior kind of emerges as barriers over time, which kind of fits with the hypothesis that I'd had that you really need to think about behavior change from the very beginning. And so we instituted again, a very similar study where we did some local technical assistance and infused some behavior change techniques and theory into the strategies that we developed. Very similar kind of patient materials were developed for more general patient population that included things like verbal persuasion information, changing your physical environment. All of these different pieces were key to making sure that it looked very simple to the patient, but there were lots of behavior change techniques infused throughout. The other thing that we instituted, because we thought that this was so key to sustainability, is we encourage them to adapt the program. Maybe you can't keep doing collaborative care the way that you're doing. You have a lot of complex patients. Maybe in the original trials, they did problem-solving therapy, but you need to get training in CBT or training in DBT. Maybe you need to change the number of sessions that you have. Like, there are changes that you can make. So we encourage adaptation to the collaborative care model during this time. And then again, this piece about the kitchen sink, we thought, okay, instead of throwing the kitchen sink at the problem, let's see whether or not we need all three multi-level components. Maybe the depression care manager is enough. So just doing the system level strategy is enough. Or maybe you do need the multi-level strategy. Maybe you need to target the care manager, the provider, and the patient as a way for us to see whether or not there are any differences. And so what did we see? We saw that the clinics who were part of the OMH program that we piloted this in saw a 10% improvement in clinical effectiveness. So this is the number of their patients in their panels who saw improvements in their depressive symptoms versus the rest of New York State, where they continued to plummet in terms of the number of patients improving within the collaborative care model. What was interesting, though, is adding the doctor piece of like bothering the doctor, audit and feedback. All of these pieces made no difference. Both saw improvements in reach, adoption, sustained use of mental health of collaborative care models during this time. And so this again starts allowing us to see what worked, what components did work, didn't work, what do we really need when we widely implement this. And then on the patient side, we saw a tripling in collaborative care enrollment. So those patients who got the tool were much more likely to enroll in treatment than those patients who didn't get the tool within this cluster randomized controlled trial. And there was we extrapolated using novel methods, the impact on depressive symptoms, and we see this kind of improvement in depressive symptoms amongst those who got the tool versus not. And as we start looking at the mechanisms of why did that work, and this is a big thing in implementation science right now, is how did this work? Why did this work? And our mechanistic, we looked at all of our minutes and qualitative analyses of our minutes and surveys of care managers, providers to get a sense of how our strategy worked. It was very clear that we somehow improved communication. So messaging between the care managers, patients, PCPs, and the adaptability were key reasons why our care manager strategy worked. Then on the provider side, the issue was that, yeah, they actually thought collaborative care was great. They found it acceptable, feasible, usable. They had high awareness of it. They thought it was their responsibility. It was just that their, relative right priority. I had other things going on in the visit, low confidence in referrals. I don't know that if I refer the patient, they actually get better, this kind of learned helplessness over time. And then on the patient side, those who got the tool just perceived fewer barriers to treatment. So it was clear that we had changed something in how they perceive treatment barriers. They thought it was like the cost was going to be less of a problem than they'd imagine, and other things like that. They also had higher trust in the PCP, those who got the tool versus the others, and some improvement in collaborative care acceptability as well. And so this allows you to really understand why your strategy works, so that when you're widely using it, you can say, okay, I need to make sure that I'm paying attention to these things because this is how and why this worked. So, future directions in implementation science, I think that this area of understanding mechanisms is going to continue to be key. I think that designing for implementation is also a huge piece. Our Roybal Center for Fearless Behavior Change, in which I'm co-MPI for, we are funding projects at the intersection of behavioral health and an acute illness, often cardiovascular disease. And so we're funding several projects. And so people are welcome to apply for these projects as well. I think we have another funding announcement probably going to be happening at the end of the year. And so this is really about designing efficacy and early stage interventions with implementation in mind, of testing them in the real world, and understanding not just whether or not you can improve clinical outcomes, but the mechanisms by which you improved outcomes is a big piece for this. The other big thing, I have a mentee who is implementing cardiac rehab. She's used a lot of the frameworks to understand why it's so hard to implement cardiac rehab, home-based, both home-based and clinic-based cardiac rehab, and then use those understandings to really design with the end in mind. Okay, if I had designed cardiac rehab from the beginning and I was thinking about reimbursement while also thinking about home, how would I have designed this? And what would that have looked like? And so she's redesigned and creating a telehealth enhanced hybrid cardiac rehab prototype and is currently testing us in the clinical trial. I think the other 1 to 2 areas that are kind of emerging in implementation science is de-implementation. So we have a trial that we just launched, I think this week, where we're thinking about how do you design a strategy so that you can get people to stop doing work, things that are just not guideline based, that are are very expensive to implement and don't actually see an effect. And so we've been really advancing the methods of how to get doctors specifically and even patients to stop something that has no evidence. It's really been very fascinating to get a sense of like how hard it is to get people to stop versus getting them to start. And then lastly, we just launched a pilot program. A lot of in the cardiac world and mental health, we're still seeing, yes, we've seen improvements in depression treatment uptake, but these are patients who are often frail and ill and they can't make it to treatment. So maybe they don't even want to talk to anybody on the phone. And finding ways to continue to provide nudges even when they get home has been very, very interesting to us. So we've put together a team of engineers and have been piloting a intervention where we pair some of the implementation strategies that I talked to you a little bit about for our cardiac intervention with AI nudges at home using Alexa and other things like that as well to see if that can be a little bit more effective at not just improving those depressive symptoms, but also the behavioral risk factors that I say really underlie that link between depression and cardiovascular disease. And then that's basically it. So these are our aims that we're going to be working on in terms of trying to see if this MLLM model actually improves outcomes in this patient population as well. So I've given you a sense of the problem overall in terms of depression treatment and in heart disease patients, how applicable collaborative care is, how important it is to maybe think about precise mechanism-driven, user-centered design aspects of multi-level strategies as you're designing strategies in your own healthcare systems, how those might be effective in improving the sustained use of an intervention. I've tailored the model. I've done this both across wide swaths and worked with policymakers. I've done this in cardiology settings, and then we're increasingly kind of disseminating our models and doing less and less as a team. I think we spent a lot of time refining and making sure our model was actually effective. And now we're in the midst of one or two projects where we're just turning things on in Epic, turning on our strategies without necessarily having to be so involved in seeing what happens truly in the real world. And the hope is that we can improve outcomes in cardiac patient populations along the way. So in conclusion, behavior is a key mechanism that connects psychological distress to cardiovascular disease. Depressed cardiovascular disease patients are less likely to receive treatments that target the mechanistic drivers of recurrent cardiovascular disease. And these kind of mechanism-driven, precise strategies designed for the context in which clinicians work and patients live and may improve implementation and sustainability. And I think the future of implementation science will really merge behavioral design with intelligent systems built not just for patients, but with them as we kind of go forward as well. So I'm happy to take any questions. I left some time at the end. Here's all the folks who've helped me along the way in terms of our implementation science lab. We've had multiple stakeholders at the policy level, clinical level, and I've worked with a ton of different trainees on various implementation projects over the last couple of years, as well as master's and PhD candidates who are doing very similar work, but in lots of different spaces and expanding out a lot of the processes that we've built out here, but in very interesting different places. I think like cardiac rehab for one of my mentees, but also cancer and telemedicine. So it's been such a great opportunity to mentor the next generation as well. And that's it.
Thank you. Thank you so much, Dr. Moise. Sorry, my voice. Um, so let's open it up for some questions. I see we had a question in the chat, and this was from Maria Morcos. I am curious from your perspective, if you think there is a different role for inpatient versus outpatient providers in providing care for these comorbid patients, and how to best design this implementation for future direction.
Yeah, that's a great, great question. We've thought about that quite a bit. I do think you have more time in the outpatient world, often, just because the length of time that you have patients with you, if we're still talking about depression and cardiovascular disease, but really anything, the length of time that you have to change patient behavior is much longer on the outpatient side. So we did think about implementing some of this on the inpatient side. It just logistically felt a little bit more difficult. But you also have a very active participant, though, who's stuck in the hospital, who's often not doing anything else, who's bored for a lot of the time during the day while they're getting treatment. And so you do have a willing person who's paying attention that you can you can at least start the process in terms of behavior change. And so there has been some data of like getting things started. I know even in the heart failure regimen side of ensuring that we've started as much as we can. On the inpatient side, it just makes it easier for patients to continue their treatment. Any of these patient activation tools or educational tools, you have a patient who suddenly had, a really scary, life-altering hospitalization, and they might be much more likely to take in knowledge during that hospitalization as opposed to afterwards. So I definitely think there's application there. It's just really thinking about your context and how busy clinicians are. So if you're doing a lot of the user-centered design work that I talked a little bit about, then you're really spending a lot of time mapping out workflows of ensuring that you're not overwhelming the already very, very busy healthcare system. But I think Epic is making things so much easier now for us to turn on and off, for us to send things. We're doing another study where we're just sending a wellness toolkit, turning on screening. Those patients who screen positive are just getting their wellness toolkit sent directly via my chart. So there are ways now that you have a captive audience. And I do think that at least getting started in terms of the behavior change interventions is very, very potentially very effective. It's just really some of the issues we've had also is that for the early implementation science, where you're really trying to track what happened, why did it happen, how did it happen, did it make an impact at all? If patients are seen in various settings afterwards and they go back to a different part of the city, for example, then it can be very tricky to figure out and track their outcomes over time. So it's really trying to find an outcome that that would be very easy to measure and for you to say, okay, this was successful. Like maybe it was picking up a prescription, maybe it's attending a discharge visit, maybe it's something that's very, very clear so that you can get a sense of like, did this work or not, without having to do too much to collect data.
Okay. Um, anyone, feel free to come off mute if you have a question. Uh, so I have a question. So, like as you mentioned, like implementation science, like that has become an increasing buzzword, and especially in cardiology. But what I've noticed that a lot of times when we have like supposed like implementation studies from cardiologists, there's more so like a focus on like patient outcomes, so like that effectiveness piece. Like, what would be your advice to like, cardiologists in training in terms of actually doing implementation science where you're being true to like understanding the methodology and whatnot for that implementation um of that action that can cause change, but also balancing the effectiveness factor because I feel like for, the older generations of cardiologists, it's very much like, well, did it improve blood pressure? Did it
Mhm.
improve lipid control? Like, how can we best balance that?
Yeah, I think that's such an interesting conundrum because we risk just redoing old research when we do it that way, where we've already kind of looked at that. And so first you have to ask yourself, is there any evidence that this works in the real world in like non-consented real world patients? If there really isn't a ton of evidence, maybe this worked in a perfect trial and you have no idea whether or not, this intervention will actually improve blood pressure in the real world, then I think it does make sense to start with, okay, does this improve the effectiveness while also measuring, did my strategy improve the uptake of the intervention? Did my strategy improve fidelity, adherence, all those other implementation outcomes? Those are the more hybrid trials. So I think what's happening is there are a ton of hybrid trials, maybe because the interventions that they're focusing on, we really don't even know if we're going to see the same improvement or impact in a non-consented perfect world. If they're just consenting patients all over again, then I don't know if that completely makes sense to redo an intervention like that. But if you're really trying to say, okay, in the real world, I'm going to see whether or not widely implementing this and giving some support. So this implementation strategy to get people to use this intervention. Let's see if this actually improves depressive symptoms. You might be surprised. You may not see improvements or in your outcome. And that's actually really important data. You're like, wow, the one outcome that I thought I would see an improvement in, we saw no impact on blood pressure or any of the other kind of harder outcomes. That should be a little bit of a red flag suddenly of like, okay. And if you keep seeing that, then is it something about my context? That's where the why is so important of like, you can get a lot of data from that of like, okay, is it because is it the setting? Is it the patient population? Sometimes that data can inform mechanistic early efficacy trials again of like, oh, there was something going on that just didn't work very well in this patient population after all. And we need to understand what happened. Was it just the lack of adherence? And if that's the case, then maybe I wasn't doing enough to ensure adherence throughout, right? And so I think you can learn something from those interventions as long as, it hasn't been done before. And then I tend to do a lot of the kind of hybrid threes where we have now, like, especially the collaborative care world, there's been 100 clinical trials of collaborative care. Like, I don't need, and a lot of them were done in the real world, right? So some of them had consented patients, a lot of them had consented patients, but some of them didn't necessarily. So there's way more than enough like data. So I don't really need to test depressive symptoms again. I can as a secondary or tertiary outcome, but I really care about, did I implement this? Did I improve uptake? Did I improve fidelity? And so I really think it's really dependent on how much evidence and where that evidence is coming from for the evidence-based intervention.
Anyone else with questions or? Well, I have another question. Um, so like when you design some of your interventions, like do you ever start with in mind like how am I going to scale this? And I know you scaled this intervention, this particular one, like New York State, but like thinking about like a focus like even like nationally. And
Mhm, mhm.
have you, as an implementation science researcher in the cardiovascular space, have you identified like partners, like, the professional societies or what say you policy groups
Yeah.
that are interested in providing that sort of like support to really like make a whole national rollout?
Yeah, yeah. I do see a lot of like ARC and other funding mechanisms are asking for these more dissemination projects now of like, how do I disseminate this across a wide swath? I am seeing more national projects as well. And so I think for those where the payers are so, it's very interesting because you have to think about reimbursement and differences by state. But I think you can learn quite a bit. And one good example is like the Food is Medicine initiative that AHA is implementing really across I wouldn't say it's completely implementing, but they're funding these. And that's been a really nice way to kind of do a lot of the piloting and the buildup of this entire initiative across the country. So funding becomes very key for something like that. You need national partners, you need insurance companies involved, you need, right? And so often that kind of work, in order for you to really do that kind of work, it probably makes sense for you have to work with a policymaker to make sure that it's going to be reimbursed. And I really think insurance companies have unfortunately, potentially, but I think they have there is a lot of potential. We're starting to see insurance companies implementing like, things like physical activity, reimbursement and getting people to exercise from that perspective. There is, I think, some really interesting work to be done, but I think it may even be easier if you partner with an insurer. And then you also have to just think about your evidence-based intervention. Some interventions don't need that much work. I'm working in behavioral cardiology where we have really complicated evidence-based interventions that work, but they're really complicated and clunky. And so it takes a lot of effort to widely implement programs like that. Um, but there are other things like Ozempic, like that didn't need a ton of, and I think this is why designing for implementation is so important. Like it just needed a little bit of marketing, and now everybody's using it. Everybody's trying to get their hands on it. And so I think we underestimate marketing is an implementation strategy. So if you want a national scope, you need something that people want, that works, and it gives you a sense of like what needs to be in an intervention for people to widely use it. I think that's been a nice, interesting use case, for better or worse, of getting people to use things. And people are trying to do it regardless of how much they have or funding. They're finding ways around it. And so when you have an evidence-based intervention and you design with the end in mind, you design something that people want and need, the implementation becomes a little bit easier, especially if you're thinking about things at a national scope.
Mhm. Thank you.